Good morning, respected chairperson, teachers, and today we will be discussing a 2-year-old male child, resident of Bihar, who presented to us with incidentally detected abdominal mass. So, child was apparently well till 4 months of age when he was incidentally diagnosed to have a left abdominal mass on ultrasound. While child was admitted for fever and URI, there was no features of abdominal distension, recurrent fever, vomiting, respiratory distress, or lump anywhere in body. No urinary complaints or hematuria was there. No history of seizure, difficulty walking or delayed development. No history of constipation or loss of appetite. No history of voice change or hair growth in axillary, pubic area or face. No history of easy bruisability. No history of recurrent infections. And no history of headache, blurring of vision or palpitation. There was no significant family history and no significant past history. On examination, the general condition and vitals were normal. There were no neurocutaneous markers, and per abdomen was soft with no lump palpable and no tenderness, and bowel sounds were normal. Other systemic examination turned out to be normal. On routine blood investigations, the hemogram and RFT were normal, and urinary VMA and AFP was also normal. Ultrasound, the patient presented with an ultrasound done elsewhere at 4 months of age, which indicated query a left kidney mass or a left suprarenal mass. When he presented to us, he was for 6 months of age, and a CCT abdomen was done in September 22, which revealed the possibility of left cystic neuroblastoma or query adrenal hemorrhage with size of 8.5 into 7.8 into 6.5 centimeters. So this was the CT scan, and here it shows a large 8.5 centimeters mass in the left suprarenal area. And another notable finding in this CT scan is the compressed left kidney, as can be seen in this image. So in view of a left suprarenal mass, we proceeded with a metastatic workup. Bone marrow aspiration revealed no evidence of metastasis. Skeletal survey, including skull, spine, pelvis, and limbs, were normal. Technetium MDP bone scan revealed no metastasis, and ultrasound guided FNAC was attempted by us, which was inconclusive. So this is MDP bone scan, which shows no evidence of metastasis. MIBG whole body scan was also performed, and no pathological uptake is seen in this image. As patient was clinically asymptomatic and investigations, including MIBG and metastatic workup, were normal, he was kept on active surveillance and planned for repeat scans after 6 months. So, requesting for
really appreciate the person who did the primary ultrasound abdomen at 4 months of age when the child was admitted with URI. Who does abdominal ultrasound when URI, patient presents with URI? So it is great because we picked up something. And I also want to know what was the difference between the findings at 4 months and 6 months?
Actually, at 4 months, the ultrasound was from another center, so they only mentioned left kidney mass only. So when the patient presented to us at 6 months, we did a preliminary CT scan to better characterize the lesion, which revealed a 8.5 into 6.5 centimeters mass. Yes, 6 months. Yes, 6 months. Now the child is 2 years.
What are the differences that we would think of at presenting at such a young age with a cystic mass in the suprarenal area, and how should we have proceeded?
I think that we would really need an MRI for that, and to have a look on the. I think that diagnostics is incomplete yet. It is something only little active, not neuroblastoma of active type, very kystic. I would suggest to do MRI, because at MRI we will get nice coronal scan, nice frontal scan. We will be able to see better the relationships to the surroundings, better than on a CT, especially that this CT was done in a low radiation mode because of age. So you don't have very high resolution. So that's my suggestion. And the size is quite impressive. It is not a small thing, and that's why I would not think about a simple hemorrhage to the adrenal that could be 2 centimeters big, but not as big as that one.
Yeah, so large cystic mass, how many of us will biopsy this tumor?
Well, I have a question. Is the mass septated? Is it multi-compartmental?
No, so it was also homogeneously cystic only.
Yeah, but
No
it's
solid
one big
component.
cyst or several cysts?
So single cyst only. There was no heterogeneous component or solid components in this CT scan at least.
Maybe show the
Because
scan
it
again.
can be a mesenteric cyst, it can be lymphatic malformation. It doesn't have to be anything oncologic, you know. So I think probably myself, I wouldn't just follow the patient without diagnosis. Like Jan, I mean, we would try to do MRI or we would try to do maybe more detailed ultrasound. I think it's a big mass in the end.
I would like to add something. Actually, there is no complete imaging available here. You have shown one scan only that is showing, in fact, that image is not showing the kidney also. Posteriorly, some tissue is seen, but that is not kidney. So we cannot see separately the adrenal gland on the left side also. So you have to have the complete image.
Wrong CT scan. The entire
Yeah.
CT scan with coronal and sagittal section.
Yeah, CT scan is nowadays quite enough because we have multi-slice CT, we can do triple phase CT, and CT can demonstrate most of the thing. In fact, we have not tried to sort out whether they are calcifications or not. So the single image is not sufficient. You have to have the complete.
So what was the status of the left kidney? Anjan. Yeah.
No, you should have add up some sagittal coronal sections where you can show the kidney push downward and the whole set of tumor itself. And patient was
And what
not-
about the left kidney, Anjan? Left was separate. So that is a very crucial information, I think, as ma'am is saying.
when left adrenal gland is not seen separately from the lesion and the left kidney is pushed downward or posteriorly, so it should be separate. So it's definitely suprarenal. Now it comes about the differential diagnosis.
Yes.
In suprarenal, in this age, if it could have been adrenal hemorrhages or something, so there should be something like it could be acute, subacute, or chronic hemorrhage. So that has to be correlated with the presentation of the clinical presentation of the kid. And that
So
can be,
adrenal hemorrhage, ma'am, can it be completely cystic without loculi or septae or echogenic debris?
in
Can
that
it
case,
be?
in that case, mostly the size is, the shape is maintained, size
Yes.
can be enlarged. But depending on the stage of the hemorrhage, it could be acute, subacute, or chronic. So in all three phases, you can see temporal resolution of the hematoma. That can very well be differentiated on CT also, but better is MRI. And otherwise, the presentation, clinical presentation of the kid also, whether he is having adrenal insufficiency or something, that I think it was not there.
Yeah.
And nephroblastoma, neuroblastoma can be cystic, associated with calcifications and all, and that can insunate between the adjacent structures, displacement and all. Here, only the kidney is displaced downward and posteriorly. So adrenal hemorrhage can very well be differentiated from tumors.
One extra questions. What was the Hansfield score of the liquid inside?
Sorry.
Hansfield unit
Okay.
score.
Hounsfield units.
It must be like if she thinks it's.
If this is 30 to 40, this is a blood. If this is 20 or 10, this is just the
It appears to
fluid.
be here less than 20.
Yeah.
Fluid density.
Yeah.
Mike.
Did you look at the flow by Doppler in the mass? Because a neuroblastoma is more likely to have a blood flow by color Doppler, whereas cystic hemorrhage will not be having a blood flow likely in that. Also, if they has it become bigger or smaller, what has happened? You could have, that is very important.
Is required actually.
From 6 months to 2 years,
Yes, ma'am,
what
I'll
has
be-
happened to
yes,
that?
ma'am, I'll be coming to that.
Also, like, I would have probably admitted the child catheterized and sent a 24-hour That is non-invasive. You're saying
Urinary VMA was normal, sir. Yes, yes.
I mean, neuroblastoma diagnosis is rather unlikely here, you know. Of course, it may happen you have a cystic neuroblastoma, but it's pretty unusual. You don't have MIBG is negative, you don't have catecholamines, yes, I presume, or of HBA or VMA. So maybe it's a benign lesion, you know, and really MRI is essential. You have to remember that in small children, young infants, neonates, resolution of CT is very limited. It's really limited, you know, because they have little fat. There is no good separation of various structures. And especially in cystic lesions, MRI is indispensable, really.
So the child was kept on active surveillance, and at 1 year of age, ultrasound abdomen was repeated, which revealed more solid component in the left suprarenal mass. However, CCT was further done, and it reported a decrease in size of mass to 5.9 into 5.6 into 4.5 centimeters. And it was a left suprarenal solid cystic mass, which had increase in solid components. As solid components had increased in mass, in view of suspicion of malignancy, MIBG was repeated. And on repeat MIBG, no pathological uptake was again seen. So this was the CT scan which was repeated, and it showed a increase in solid components. And this is the MIBG which shows no uptake. Core biopsy was attempted at this point of time, but could not be done as solid components could not be localized from the mass. After 2 months, we did an MRI abdomen to better characterize the lesion, and it showed a 5.5 into 6 into 5.2 centimeters left suprarenal solid cystic mass encasing aorta and left fetal pedicle with more than 180 degrees of circumference with small and compressed left kidney. An FDG PET was also done at this point of time, which revealed a 5.2 into 5.2 into 4 centimeters mass with necrotic areas with query minimal peripheral metabolic activity. So this is the MRI which was done at 1 year, 2 months of age. This is the mass which can be seen. And on coronal section, we can see the mass. This was the FDG PET, which showed only query minimal peripheral activity and no other pathological uptake. So requesting your views on the same.
I think instead of FDG PET, we could have done a Dotanoc PET. So what is the sensitivity of Dotanoc PET as compared to MIBG? It has come up in recent years. So we are using Dotanoc PET a lot because the MIBG study happens once a month. So the dates for MIBG are really long at SGPGI. But the Dotanoc PET, we are able to do at least every second week. So
Dotanoc
be
PET is more
better.
specific for pheochromocytoma and other endocrine tumors rather than this neuroblastoma. For neuroblastoma,
No,
it is more sensitive than the Dotanoc PET.
But we are using.
I'm not sure of that, sir.
We have done in our
FDG versus Dotanoc, you're saying FDG is more sensitive?
for neuroblastoma.
MIBG. No, sir is saying about FDG, you're saying about.
And
MIBG,
FDG
okay.
will take activity of any hyperactivity.
Yeah, exactly.
It will not be specific, but it will be sensitive to pick up. But Dotanoc PET is more specific for PO.
But it picks up neuroblastoma brilliantly. We have seen that in many cases now. So and there is literature for that. So what I was asking is whether the sensitivity is as much as MIBG. I don't have the answer to that.
In our experience, we've used DotaDate, and that has got given over the last 7-8 years has brilliantly worked for neuroblastomas because
Yeah.
of the logistic problems of MIBG. And we actually don't even get it once a month. We don't
Yes.
get MIBG because of
Okay.
logistic issues. So DOTA date, every PET scan is done as a routine part of our workup for neuroblastoma with brilliant results. Last 7-8 years, maybe.
I agree with that. Dotanode has been known to give good results. Now, comparison between these two, I'm not aware if there are any
sufficient-
studies.
Ma'am, there are many studies in.
These are anecdotal.
No, sir, there are studies.
Yeah,
There is I can share a study in the
Right
journal
now,
of.
the issue is the
nuclear medicine.
radioactive material of MIBG is not easily available.
Yes, so
So
Dotanate
now
actually-
I don't think we should even look at comparison as to which is better because the other one is not really available as such.
Yes.
But as per CT scan, it was cystic. Earlier, totally cystic. Now there are more solid components, which is
So even if a neuroblastoma matures, still MIBG will pick it up if it is from sympathetic ganglia. Even if it becomes a ganglioneuroma, it will become positive. So MIBG will be negative in about 10 to 15% when it is up from the cholinergic ganglia. So is that a case where it is from the cholinergic ganglia? Could be. Anjan? That's what I'm saying. So 10% is negative from non-sympathetic ganglia. So it can be one of those cases. We don't know. Yes. Postgan. Correct. So I think what should be the next point in this case?
One question is that initially when biopsy was done, that time it was, some fluid must have been aspirated, right? Because it was totally cystic. But there was no solid component in the first CT. So that time was aspiration of fluid attempted and studied. Oh, that would be very difficult. Yeah. That would be very
Yeah,
difficult.
but now enough of solid component is there. I would re-biopsy this case actually.
They've done it, but
Sir?
even then it is.
But that should be, we need tissue diagnosis in this case now.
So the only way to have a tissue diagnosis is to excise the mass. Excise, either open, laparoscopy, robotic, whichever method. What's your opinion?
We have one very important factor: the size of this tumor decreases. So this is not logical to have something very aggressive. And I was a little bit against the idea that this is adrenal hematoma at the beginning, because I've never seen that big hematoma. And we saw a lot of those. But maybe it's something which now organizes, and you can very easily imagine that the hematoma is a little bit encasing, surrounding also the vessels. So for me, this is not independent, sure proof of malignancy. But maybe a TrueCut now would be justified just to know what is this. It may not be malignant disease, but we still cannot exclude that. And not only malignancies are dangerous for kids. And I see that what was written here, that TrueCut could not be done because a solid part could not be identified. I'm sorry, but I strongly believe in that. I think that maybe other machine, maybe other sonographies, but it must be identified.
Yeah, true. It's not possible.
Or CT guide.
But it is very well seen on the imaging. So
Yeah.
CT guided biopsy.
Technical point at
Right.
technical point at one attempt, you can go in again. Yeah, maybe a CT guided biopsy again. Because the problem of waiting is if it encases the vessels completely and we are just sitting on it. and not starting treatment.
It doesn't look difficult. It doesn't look difficult actually. Whatever imaging you have provided, it doesn't look difficult.
I think it is seen on function of the
Yeah.
kidney is seen on CT with contrast.
So any other follow-up on this
Yeah.
child?
We did a follow-up MRI abdomen after 6 months after 6 months. It showed a 4.9 into 5.3 into 4.4 centimeter solid cystic mass at level of L2, which showed a further 19% reduction in the mass from the initial MRI scan. So at 2 years and 3 months of age, the MRI abdomen now showed an increase in size of 6 into 4.7 into 5.2 centimeters left suprarenal mass, which was encasing renal and infrarenal aorta and abutting celiac and phrenic artery origins, spleen, splenic vessels, the atrophic left kidney, pancreatic tail, and the bowel loops. So now it has shown an increase in the mass by the MRI.
And kidney in this is not very clear.
It is atrophic and
Yeah.
So that's what I'm saying. I mean, when we know the DNS, I mean, if you do DNS and the function only 5%, 7%, then it's so much easier. Go and then remove everything. Rather than
Next,
So, just summarizing the case, so the child presented to us with incidentally detected left suprarenal mass. The CT presentation revealed a cystic mass. Metastatic workup and MIBG were normal, and we attempted a corneal biopsy, which was inconclusive, and the patient was then kept on active surveillance. Subsequent follow-up CTs and MRI revealed decrease in size of mass, but increase in solid components. So MIBG was again done and it was normal, and FDG PET showed only minimal peripheral activity. So the active surveillance was continued. Now the latest MRI after 6 months revealed an increase in size of mass and vascular encasements. So we're requesting your viewpoints on next course of action to intervene also.
I am also concerned, I am saying this to surgeons, I am concerned with the exposure of radiation that this child is getting with repeated CT scans, FDGs, PET and all these things. PET as well, no? PET CT is being done. So radiation is a lot with PET and CT together. So we need to be sensitized to this, that we need to limit the exposure of radiation. Yes, please go ahead.
So from the first CCT, only the kidney was atrophic only, from small and atrophic. From the first CT scan, we have known.
size adjustment between, I don't know whether you mentioned that in ultrasound and all that, but kidney size between. So I suggest the DNS image done, it's not done. What is the go and get the mass out, kidney out.
It should be excised.
So as there was an increase in size of mass on MRI abdomen, he was planned for surgery. However, the family was not ready for the same at this point of time. He again developed 2 episodes of abdominal pain in August 24, and then he was planned for definitive surgery and counseled for the same. So we went ahead and excised the mass. So in this image, this is the left suprarenal mass which can be seen, and behind it, it was the aorta and all the abutting, the vessels it was abutting and encasing. So this is the left kidney which was retracted, and the left suprarenal mass was excised, and aorta can be seen behind the mass.
Now, what is a histopath?
As the surgery was
Yeah, he's revealing it very, very slowly. Like, yeah, that's what I do. Yeah, what? Sorry. Adrenal teratoma. Okay. But provisional diagnosis. Yeah, that might explain a lot of things. Yeah. Encasement.
Learning from this case, in the first place, when we found the 8 centimeter mass, 8 by whatever centimeter mass,
Sometimes.
cystic mass, did not appear like, a pure hemorrhagic tissue. The surgeons go ahead and do a primary resection at that point itself. Or keep waiting for 2-3 years. And then.
I think we are seeing more of these masses now because of antenatal diagnosis. All of us are seeing a lot of cystic suprarenal masses in antenatally and then postnatally. I think at least first 6 months we should be conservative. That is what I feel.
So according to Archana ma'am, she has not spoken in the mic and I don't need to speak in the mic. She says that up to 9 months we should wait. 9 months. Right, increasing in size of thumbs.
I think time is up and we are
Can I ask one question? I was recently, similarly, they were talking about that. There was another tumor which was separate from the kidney behind the liver. So I removed that too. And that was also Wilms tumor. So I had gone through the literature. Wilms tumor within the kidney and extrarenal Wilms tumor in the same patient. And I don't know, then.
Quite clear. I don't know why you say the left kidney there, because ectopic, you are saying one way.
Atrophic left kidney was there. Function was not done.
Request to all, there is little time because. Jackson, where is all the Dawah? Many people are leaving after 2 months. Yeah, we cannot. But please take it again, yeah.
So, yes, and of course, there is a possibility of extrarenal Wilms tumor or possibility of renal tumor developing from accessory kidney. But I don't believe your case was completely different, I think. And but we have a nice discussion, but we have a tumor resected. So what was the pathology?
The pathology.
Teratoma, yeah. Malignant or not? Malignant or not?
It is
Final
under
report has not come.
evaluation
This
only.
is only on work.
Thank you, sir.